Hello, everyone. Welcome to the webinar. This is Ellen Avery. I am the medical advisor for Keto with Nutricia. I wanted to provide a little bit of background for our Keto University series. This is a webinar series that we have developed based upon our Keto University program that we have held as a live event in the past. It was a training program that we developed with our Nutricia Keto ambassadors that we have now turned into a webinar series based upon current events. We are offering one webinar every other week. From the last one started last week and are now going until the beginning of September, actually. We've extended it from August until now the beginning of September. And we offer CE credit hours for dietitians and nurses in the United States and a certificate of attendance for all those other clinicians who wish to request it. We are offering 10 webinars led by experts in the field. Like I said, our last one was last week, and then today we have Jennifer Fabe here, who's going to speak on the low ratio and slow outpatient initiation and maintenance of the medical ketogenic diet. We are very excited to have Jennifer here today. So a little bit of background on Jennifer. She is a graduate of the University of Saskatchewan and received her graduate training in the area of nutritional neuroscience. She is based in Ontario and has been there since 2000 and is a longtime practicing ketogenic registered dietitian at one of the large tertiary centers in Canada. She has supported many endeavors throughout her career that include research projects, supporting Ontario guidelines for epilepsy management, and education and training of many dietitians in Canada and abroad. At this point in her career, she has concentrated her professional efforts to share innovative and practical solutions to common challenges of the ketogenic diet implementation for clinicians and patients. These efforts include developing low and slow initiation methods, which she's going to talk about today, as well as food exchange meal planning methods and co-developing ketogenic diet software. She has been an invited speaker to many academic conferences nationally and internationally. She is very dedicated to supporting community and epilepsy organizations. She proudly serves as the president of Matthew's Friends Canada, which is a branch of the global charity Matthew's Friends in the United Kingdom. So throughout the webinar, I invite you to put your questions that you might have in the Q&A box and on the lower right-hand portion of the screen, as we will be doing a Q&A session at the end of the webinar. So please put those questions in there if you have them throughout the event. The handouts will be available after the webinar, so we will be emailing those out at the end. We will also have the certificate of attendance available after the webinar. So without any further ado, I'd like to hand off our presentation to Jennifer.
Thank you, Ellen, and thank you, Nutricia, for the invitation to share an exciting area that I have that I like to share in my professional practice of the low ratio, slow outpatient initiation and maintenance of the ketogenic diet therapy. We affectionately call it low and slow here, and I'm hoping that the attendees who've taken time out of their day will get some pearls of wisdom that they can take back to the practical front lines to help their patients and their families. These are my disclosures that I will just put forward for quick review. And the objectives of my presentation is just to provide an overview of what we've been doing in terms of the low and slow initiation method here in Canada. So to provide sort of an update on the data that we've collected since 2018, when is the last time I presented to you, as well providing the practical calculation examples of using the low and slow outpatient method that might be useful for clinician and registered dietitians globally. And hopefully, again, you'll get some pearls of wisdom through that, and address any questions, of course, about the low and slow outpatient initiation method. Now, as my introduction has revealed, I have been practicing for quite a long time, so I'm going to do a bit of a comparison of the initiation via inpatient method, and then to develop on that the rationale for the development of the low and slow inpatient methodology, and then also provide you the dietitian practical perspectives on all of these methods to take forward into your practice. So the rationale for developing the low ratio, slow outpatient initiation method. So way back in 2000, I had inherited a ketogenic diet practice at my hospital center. And across many centers, not just mine, but across many centers in the world, there was the tradition of using inpatient rapid initiations. And by that, for the audience, it meant that you admitted the patient into hospital, and the admission would last anywhere from 3, sometimes 5 days, sometimes a little bit longer. And you may or may not begin that initiation with a fasting period of not eating any food to achieve sort of a more rapid ketosis. But the idea was to rapidly titrate the diet prescription upwards and then discharge the patient to home for further support. And so here I provide an example of sort of the outline of what a typical titration outline would be. So on day 1, you may or may not fast when you admit the patient, and then on day 2, advance the strength. And then if tolerating, advance the strength further, and so on and so forth. And then once your team feels that they have achieved their goal prescription, they would discharge home as long as the patient was stable. And then ongoing support into the outpatient community would be provided through the dietitian through phone support and menu support. And for some, that would come up to support of 4 to 6 weeks ongoing. There would be monitoring of metabolic fluctuations such as blood work and monitoring throughout that admission, and then teaching of that monitoring would continue on into the community. Now, the teaching surrounding an inpatient admission would also either, what I hear from many centers is it either occurs just before the admission or during that admission. And I bring that to a point because it leads to sort of the practical use of a dietitian's time. So often, a dietitian would be split between sort of the inpatient and outpatient world. And so looking at the challenges of inpatient initiation, you see that in the metabolic sense, with the patient, you are rapidly changing the diet within days. The diet may be achieving a more restrictive prescription than is perhaps necessary because you don't have the time in between those days to really evaluate efficacy for seizure control because you're changing it on a daily basis. And possibly with these rapid titrations, when you're shifting the macronutrients fairly quickly for fat, protein, and carbohydrate, you may encounter side effects, which are transient but still occur and is somewhat unpleasant for families and patients, is the hypoglycemia, potentially the acidosis, the nausea and vomiting that is associated with both of those, and potentially diarrhea. So the challenge for the keto family is that if there's caregivers involved, whether it be parents or associated caregivers, there might be a time away that's required from away from work, and so that might not be practical for them, or they don't want interruption in their income. And as well, learning in a hospital environment, in an unfamiliar kitchen facility, the distractions, and also limited to the foods that you can bring into the hospital or limited to the foods that the hospital can only provide. The challenge to the hospital. Now, in a socialized medicine model that we have in Canada, we are publicly funded, and we have bed availabilities that are always almost maximized, and especially in my hospital. So bed availability for these admissions was very challenging to do. And so that was one big practical model that we had to kind of evaluate. And as well, there is a potential if the side effects were significant enough that it would result in extended length of stay, which would then extend the cost to the public health dollar regarding this admission. And for the dietitian, as I mentioned earlier, when a dietitian is, using their time, sometimes we have to use our time very practically and efficiently. And often across the world, what I have seen is a dietitian is sort of the quarterback for the therapy. And they may not just be exclusive to ketogenic diet therapy. They might have other duties to be balancing out. So it is important to use the dietitian's time responsibly. And it is more challenging if they're also trying to balance inpatient work along with outpatient support as well. And this could result in overtime hours, which again results into public healthcare funding issues or budgetary issues. In terms of the practical side of the ketogenic diet, when you're titrating it, whether it be outpatient or inpatient, you have a different sort of language, and this is another basis for developing low and slow. And so the traditional nomenclature of using titrating ketogenic diet is using ketogenic ratios. And for the new people in the webinar, the ketogenic ratio is really a mathematical equation where your numerator or your top number is the grams of fat, and it is divided by the sum of the grams of protein and carbohydrate, and it is expressed in terms of fat in relation to the sum of grams of protein and carbohydrate. And we typically will try in communicating in sort of 0.5 increments, and sometimes you hear these ratios of 3-to-1 and 4-to-1 being discussed, but it is a reflection of a mathematical equation. And when we titrate the ketogenic diet in terms of this nomenclature of ketogenic ratios, we often do it, like I said, in 0.5 increments. So you see in this very beautiful sort of stepwise titration method, it is really a mathematical equation. But to appreciate those who are keen to the math, you will see that when you're increasing the fat in a ketogenic diet, the numerator will increase, and the protein may stay the same, and the carbohydrate will decline. So your mathematical equation is not always of equal titration, and I'll demonstrate that a little bit further in the next slide. So when you're talking in nomenclatures of ketogenic ratios, it can be a bit difficult to describe what you're actually doing to your patient and to describe it to your team. And I have encountered these practical communication challenges myself. And so if you look at the example here of a 3-to-1 ketogenic ratio, which is a common ratio that we use in our practice, you can see that the numerator, grams of fat, is the same, 116 grams. And you go over to the protein column and you see that the protein differs. And for a 15-kilo boy, 14 grams of protein is not impractical. It meets the recommendations, but I wrote 2 prescriptions because this particular boy needed a bit more protein for palatability. And what that translates over in terms of carbohydrates, was a vastly different amount of carbohydrates. And in our keto world, we know that a difference of 14 grams of carbohydrates within the day is a significant amount of difference to improve palatability in food choices. So when you're communicating in ratios, you don't necessarily appreciate the macronutrients from face value of just hearing the ratio value itself. You have to break it down. So from here, I'll describe to you, based on those sort of 2 principles of inpatient rapid initiations and sort of nomenclature of ratios, how we developed the low ratio slow outpatient method. And so like our recommendations, the consensus statement, we will always make sure, the team and the physicians will make sure we screen our patients for inborn errors of metabolism to make sure that they don't have conditions that are contraindicated for ketogenic diet. We do start with an outpatient teaching session, and that can last anywhere from 2 to 3 hours in an outpatient session. And practical perspective is that can be done either a face-to-face clinic visit, or it can be done through virtual telemedicine that we actually do here in Ontario. So we can teach online, or we can teach in the practical sense. Many who have the option will choose to come in face-to-face and have that conversation with us. But I think in the world of pandemic, we've shifted and done a lot of visual training, and that's just a sustainable and convenient for the families. And as well, we do, the dietitian will gather a 5-day diet history, collect from the family just to get baseline nutrition history. And then, of course, we'll do the routine baseline ketogenic blood work and a baseline ECG at our center. And then we migrate over to our first step of the ketogenic diet. And I include it because step 1 is a titration of using the diet in its practice form. So we usually will have a diet that when we get the diet history, it'll be about 40%, 35, 40, 45% calories from fat. It will be always adequate in protein most of the time, and then the remaining calories coming from carbohydrate. So with that initial, sort of baseline analysis, we'll usually jump first to 60% calories from fat, and then achieve protein adequacy. Usually we lower the protein a bit, and then make up the remaining calories from carbohydrate, which will be a titration downward from the usual baseline diet. This is a practical step. This is not a therapeutic step. And sometimes we skip this step if we need to move a little bit quicker. So I just mentioned that as a quick mention. So we start at 60% if we feel it's deemed necessary, and the families can actually start, figuring out their groceries and how to prepare methods. But it usually isn't a therapeutic step. I've only had a few where I've achieved seizure freedom on that step. So after you've taken that step, you jump up. So take another 10 or 15% titration up in your percent calories coming from fat. Note that I'm not talking in ratios anymore. And maybe you'll hit around a 70 to 75% calories coming from fat. I'll choose a protein requirement, again, that meets the daily requirements for that individual to make sure that they're not losing muscle mass and supporting growth of their children. And then the calories from the carbohydrate will make up the remaining part of the calories, and they'll always titrate down lower because you're always taking up calories from fat. And at this step, you may consider adding MCT oil or not. But the take-home message is that the keto ratio is a result. It isn't our goal. It will come out of the math when we are titrating up by percentages. And we will remain at this step for 7 to 14 days, again, to afford a bigger window to watch and observe whether that prescription is effective for that particular patient. It allows for easing of the side effects. It allows for making small mistakes as they meal prepare and adjust their lifestyle and get their groceries, etc. And then if the step is still not strong enough to achieve the acceptable seizure control, in agreement with the team, we'll continue to move forward onto titration step 3. At home, we'll be expecting the caregivers to monitor things like sugars and ketones, urine ketones, their bowel movements, and seizure control. It is the goal, sort of our goal to have all that monitoring to be done at home, and then if we need to, we can monitor via a local lab with acidosis blood work, if it's deemed necessary. And again, we move on to titration step 3 if titration step 2 is not achieving adequate seizure control, and it's a smaller step. We'll titrate up by another 5 or 10% in calories from fat. Same practice, the protein likely remains the same, and then we'll make up the remaining part of the calories from carbohydrate to achieve the ketogenic diet prescription. You may or may not consider MCT oil at this time so that you can keep your carbohydrates broad. And again, the take-home message is the keto ratio is not our goal. It actually is a result of our math, and it is not our goal. And the duration on this step can be anywhere between 7 and 14 days, or you maintain at this step if seizure control is adequate. The home monitoring expectations remain the same, and if we need to, we can use local lab monitoring if necessary. I think in our practice, we realize that that's not always necessary. And then so on and so forth. And then another step 4, we again advance by another 5 or 10%. Keep the protein the same, add the carbohydrates, and then again the ratio is the result, not the goal, and you continue to support and fine-tune the diet using different food types that your dietitian might suggest, or different menus and recipes. So the dietitian and the team work in concert with the family to make sure that the that the person is growing appropriately if they're children, or maintaining adequate weight if that's their goal as well, or achieving their healthy weight. Will fluctuate mildly the protein and carbohydrate, but keeping them within the prescription to support palatability and efficacy for seizure control. A registered dietitian will create menus, sometimes for the families, to best fit the prescription to optimize palatability and eventually sustainability. And we often provide weekly or biweekly monitoring and support via phone or email. And like I said before, we're now moving into sort of virtual visits where we do it via video and audio telemedicine now, which has been sort of our standard of practice for almost 15 years. So, we're just adding the video component a bit more frequently, but, it has worked for us for so long, and I think the families really appreciate the support. And I think it reflects in our sustainability data as well. And then for clinic visits, face-to-face clinic visits, before pandemic, we would have the families come in at the 3-month mark to check in with the physician, at the 6-month mark, and then every 6 months thereafter. But again, right now we've shifted to virtual visits, and we'll be revisiting that as time goes on. So an example of the low and slow titration outpatient initiation method, using a pediatric case of a 4-year-old male of 15 kilos and requiring 1,200 calories, you can see here that I took a baseline diet of, you can see on the left, 33% calories coming from fat and 53% calories coming from carbohydrate, which is a very typical energy distribution that we see in North America anyways. And over to the right, in the purple boxes, you see the translation of what that is in grams of those macronutrients. And like I said, sometimes we take a step 1 or a pre-step 1, and we just jump up to 60% and calories from fat, and that step is usually not therapeutic, but it is a great step to make lots of mistakes for the family to figure out their groceries and practical meal planning steps, and kind of get their weighing down or measuring down that they need to. And then you see that the carbohydrates have dropped. So I've dropped the protein as well because I want to achieve protein adequacy. For this particular patient, we couldn't drop it down to the usual DRI of about 14 to 15 grams of protein. We had to keep it palatable for buy-in and commitment, so we increased it to 27 grams, which is about 1.8 grams per kilo, which is still very adequate without risk of gluconeogenesis. And then we made up the remaining calories coming from carbohydrate. The tolerance there was quite adequate, and so we moved again up into 70% calories from fat, and then 80% calories from fat, as you see in this table. And if you move your eyes to the right, you can see that the fat jumped up in sort of equal increments of 13 to 14 grams with each step. The protein remained constant for palatability, and then the carbohydrates took equal steps down of 30 grams each. And so by providing percent calories from macronutrients, it allows for the clinician to understand more precisely the description of the ketogenic diet prescription, not only for your team, but also for the patients, and understanding why they have to use the numbers that they do. So what is the update of us using our method here? So it is, the low and slow method was really born out of the inpatient issues that we had in terms of bed availability, lots of overtime hours, some dropout that we weren't appreciating because I don't think the families wanted to change their lifestyle that quickly in a matter of days. And so we birthed out the low and slow method very slowly in 2005 forward, and has now become our standard of practice and continues to be our standard of practice at our McMaster Children's Hospital. And so we in perpetuity collect the data just to review our safety and tolerability. And I never thought that it would be something that I would be sharing with the world, but it is something now that we're proudly sharing because it does offer a very low side effect profile, as you'll see, and it's shown to be very practical because we can achieve good seizure control at lower sort of ratios or lower percentages. So from the data that you see here, the data was gathered from tube feeding, exclusively oral feeding, as well as combination of tube and oral. I just took a snapshot of data from about 45 of our patients that we initiated consecutively. And you'll see that at the 1 month mark, and just reviewing my methodology, you see that at the 1 month mark, we are still titrating in that 1 month mark. They might be at step 2, they might be at step 1 still, 1 or 2. And so the percent calories from fat is still a little bit lower at 76%, but it ranges, as you see, from 58 to 89. And then the percent calories from carbohydrate is sitting at about 14%. And with that, you do start to see a seizure response, where about 50% of our patients in that cohort were able to see a 50 to 90% reduction in seizures already. And as we titrated further, which happens, they usually achieve goal keto prescription by about end of 1 month or end of the second month. And then we collect the data through the third month, and you see from 3 months onwards, they're sort of sitting at the same sort of prescription. So around the 80% calories from fat mark. Their carbohydrates are sitting at around 95% or 9.5%, with a vast range of only 1.5 to 30%. So a big range of carbohydrate calories. And then the ratio sits around the 2 to 1 range, as you see across the board as you go up to a year. And you can see that over time, the seizure control sort of stabilizes. About 30 to 40% of our patients will have 50 to 90% reduction in seizures. Some will have about less than 30% of ours will have less than 50% reduction, and some will actually achieve successful seizure freeness or greater than 90% reduction. But to appreciate the table, I just want to say that at the 3 month mark onwards, you're seeing a fairly stable achievement of the ketogenic prescription, achieving a ratio that's quite lower than the traditional 3 to 1, 4 to 1 ratio. And if you look at the sample numbers, they're sustaining. We have families that stay with us. We only had 3 that discontinued with us due to ineffective therapy. But just to take home that message from looking at that table. The other sub-cohort going into our low and slow method is many of us who are practicing ketogenic diet therapy will appreciate that oral feeders, whether they be in part or exclusively oral feeders, have a more challenging time making their diet more practical and sustainable. And so, and we're no different where we are too, and I've felt those pressures as well. So I took a cohort of that population and took a snapshot of that and evaluated what would be the efficacy of our food exchange meal plan. And again, I'll explain our food exchange meal plan in a moment, but we use this meal plan as a method to make it more practical to implement oral feeding and meal planning, as well as make it more efficient for time use for our dietitians. And so with using the food exchange method, we took a snapshot of 20 patients who were receiving greater than 50% of their nutrition orally, and wanted to see if it had any difference in terms of their seizure frequency reduction. And what we see on the graph on the left, we see that at, again, 1 month when the diet is still titrating up, you see that in the red bar that there is, that about 50% of our patients, much like the data presented earlier, are already having a 50 to 90% reduction in seizure control, and some are having more than 90%. And you still have some that have less than the response rates in the blue bar there, with only about 40% having less than 50% reduction. But as the month goes onwards, at 3, 6, and 9, you sort of see that red bar of 50 to 90% reduction sort of increase or stabilize. So we were thankful to hear that, at least the food exchange method was effective and could give us some sustainable seizure control, but as well wanted to see if it would actually help them stay on the diet further. It was our hypothesis. The data is not presented in this presentation, but we had done another project where we surveyed the families as to what makes the diet challenging, and no surprise, it was the meal preparation methods for the oral feeders, and sourcing out the foods and creating palatable menus that made it sustainable. So that was sort of the impetus to create a food exchange method. And with that, we found that we were able to sustain the number of patients on our caseload all the way up to a year. And I feel that we have similar data if we extend it beyond that 1 year mark. And we only had one that discontinued at the 1 year evaluation mark because the diet was not perceived to have effectiveness of seizure control. And that's a good point to mention, because it wasn't because the diet was unpalatable or it lacked variety. It was just because the therapy was ineffective for them. So implementing the ketogenic diet macronutrient goals into practical plans for patients. So the goal of the low and slow initiation method using a food exchange meal plan is to try to find the lowest effective ketogenic prescription, so you have the least restrictive diet possible. You want a flexible meal plan for the child and the family and the adult. And you want to also, again, save your dietitian's time from preparing detailed menus and recipes. So using approved food exchange menu lists can be created and you can use it in meal plan prescriptions that are provided by your dietitian. These food exchange lists can be supported, can support cultural preferences, allergies, food availability, and using the low and slow method allows for bigger windows of time to titrate between each of your meal plan methods to determine the best seizure control. And using smaller and more even numbered titrations helps reduce what we feel is side effects of the induction, which is data I presented in my initial presentation in 2018. And the child and caregiver can adjust to the diet at home, in their home and in their community using community foods and doing it at a much slower, practical pace for them. It's a much more efficient use of dietitian time. I'm a testimony to that. And I can initiate more patients at once when I use an outpatient method without fear of creating side effects. And using my practical food exchange lists. And of course, in our socialized medicine perspective, we are reducing our hospital's cost spending. So here is a case again of the same boy, 4 years old, 15 kilos, requiring 1,200 calories. And he had myoclonic atonic epilepsy, and he had about 30 seizures weekly with a generalized tonic-clonic type and atonic type. And with this keto prescription that I did in macronutrients description, you can see I titrated up using my steps. Take your eyes over to the fat column, and you can see starting at 46 grams of fat, I took the calories up to from 33% calories from fat all the way up to 60% as my step 1. And then I continue to follow my steps all the way up to titration step 3. And you can see it at that point, if you take your eyes over to the right, the ratio achieved about a 1.5 ratio to 1, and he already experienced about an 85% seizure reduction at that lower ratio. And you can see the carbohydrates are still quite liberal at 36.6 grams of carbohydrate, which is very palatable for the diet to have sustainability. And then to, again, strengthen the diet further, rather than increasing the fat, overall fat percentage upwards, I just started to use a bit of MCT or medium chain triglyceride oil in my sub-step 3, but my overall percentage of fat still remained at 77.1%, and the child eventually achieved seizure freedom and continued to achieve seizure freedom for that year. And in terms of side effect profile to the right, common to what our data suggests, the patient experienced only one hypoglycemic event, no acidosis was observed, no nausea, no vomiting, no diarrhea, so no unpleasant experiences with the onboarding of the diet. The achieved urine ketones that we often see in literature of between 4 and 16 millimoles, and the sugars remain nice and steady within a tight frame of 3 to 4 millimoles per liter without symptoms of hypoglycemia. So what are these food exchange lists? These food exchange lists that we use are very practical. We developed it based on sort of the food exchange lists that do out of the philosophy sort of the food exchange lists that exists out there in the community. So we often see it in the diabetes world, but we see it in the metabolic world, the renal world, etc. And they all have their sort of algorithm of what an exchange should be. So many years ago, I said we probably can do the same. And by achieving an exchange list algorithm, we probably can save time not only for the dietitian, but also the family. And so today I'm ready to share those sort of simple algorithms that we have for you, where it's based on two criteria, where the protein exchange is based on a calorie requirement as well as a gram of protein requirement. The same with carbohydrate, where a certain gram exchange is usually a 3-gram carbohydrate exchange. Protein is anywhere between 3 and 5 grams of protein per exchange, and the fat is about a 5-gram fat exchange proportion, but we do have to respect the calories that each provides so that we can hit our calorie goals as well. There are many foods, as dietitians know, that are a combination of both typically protein and fat sometimes, and so if they meet criteria 2 or 3 above, then we'll consider that a combination food. And so rather than going to the very busy slide that I showed you earlier where it was macronutrient distributions and percentage calories from fat, the families really don't need to always know that information. Some are keen to know it, but they need to see what the practical prescription looks like. So rather than giving them the percentage calories and the grams of fat, you give them exchange meal plan prescriptions. So here's an example, a real-life example of an older girl. I used an older girl because the portions were a bit bigger, of using sort of her titration steps of what we used for meals. So she needed 3 meals a day, so this is all calculated per meal. And what you just need to take away from it is just it's a very more simple prescription. I would only give her sort of the top 3 lines of the prescription of how to titrate her diet upwards. And here's an example of another teaching tool that I use where it's used for this particular one is only 3 steps, but I broke it up into meals and snacks because some people want to have snacks in between their meals as well. So we try to cater it to their lifestyle. And then, of course, we have these exchange lists that were created. And they were created really out of a labor of trying to test out this exchange list sort of practice that is used in other areas. And we created through the efforts of many dietitians over the years, laboring over the Canadian nutrient database as well as some custom foods out there in our community. And we created our sort of database of carbohydrates, proteins, and fats, and as well as our combination food exchange list. It is specific for Canada. People often ask me about having copies of this, but it is many, many pages of Canadian foods that are sort of converted over using the criteria I described earlier. And when we use the prescription over here as a practical example, using the same girl, the 12-year-old girl, who's 22.5 kilos, exclusively orally feeding, and you have the prescription that now is in front of you, how do you translate that into a practical meal using exchange lists? Now, this is a busy slide, so I'm just going to give you a practical example of using, creating the meals for step 1 and step 2. On to my next slide, using my exchange lists. So I suggest always to start with the carbohydrate choice. It always serves as the base of your meal plan. And in step 1, the recommendation was to use 10 choices. So they go to the exchange list that we give them, which is a hard copy booklet, and they choose 10 choices of that carbohydrate. Now that choice can be the same choice over and over. So for this example, she chose a whole wheat slice of bread, which is equivalent to 5 choices. It doesn't have to be 10 different choices, but she chose to take 5 of her allotted choices and use that up as a slice of whole wheat bread. And the remaining she decided to use as 2/3 of a medium banana. Very practical, very quick to provide. And in her step 2, she decided to introduce a bit more variety to herself. So going up in step might mean that you're taking your carbohydrates down, but it does not mean that you have to reduce your variety. So she, of course, took her carbohydrates down to 6 choices, which meant that she had less bread and less banana, but she added some strawberries as well. Very practical and very mainstream and very easy to find in your community. The next step I suggest is then move on to your protein choices. And for this case, it's looking like a breakfast. So she puts an egg. And so with that egg, it's equivalent to 1 choice. So she used that 1 choice to sort of somewhat fulfill her requirement there. And then onwards to the fat, she used for the step 1, 6 choices, and used her exchange list. And for that, she used whipping cream, margarine, and peanut butter. And the amount of whipping cream increased by 1.5 tablespoons into step 2, but the margarine and peanut butter remained the same. Again, when you kind of look at the meal assembly there, you could probably scramble that egg and add a little bit of margarine to fry it with a little bit of whipping cream. And then the peanut butter can go onto the whole wheat bread. And if there's any whipping cream left over, then it can be actually consumed or drank. Or if wanting in step 2, you can whip it up and add it as a whipped cream topping to your strawberries. Again, practical, there's variety. And if she didn't like the meal plan that was created for her or that she created for herself, or she ran out of certain foods, she just goes to her exchange list and swaps out. So the advantage of food exchange lists is that it provides families a wide variety of choices of food substitutions if they need it. It offers independence to the families to create their own meal. You can adapt the exchange list locally to food availability. And for me, as the dietitian, it certainly has freed up my time for making meals and snack recipes. I don't do that very much in my practice anymore. I allow the families to create their own meals and recipes as long as they stay within my practical meal plan exchange system. And many enjoy having that independence. And then it allows the dietitian, from a practice perspective, to allow us to work at the top scope of our practice. We get to help set the ketogenic diet prescription, but we have less of the sort of that administrative work of having to create meal and snack recipes. We can guide them to the foods in the communities, etc., and give them some more higher level practical solutions, but that meal creation could start with the family. And sometimes you can use household measures with the exchange list, or you can also use the scale, which is our traditional method, for most of the foods that are included. The disadvantage of food exchange lists is that there are going to be families that don't want that decision making, and I've encountered that a few times as well. And the dietitian has to step up to support the menu creation, and that is always good to do. And over time, you might build in sort of the encouragement and strategy later down into the therapy to empower them to start to create and have the confidence to create their own meal. If the families struggle with fractions, and we've encountered that too, we simply just try to adjust the prescription so that we're using only whole numbers, so that there's no math that's sort of required in terms of doing half exchanges. And we've also found that not all foods are translatable to household measures fairly easily, but it is possible, but it takes a little bit more time. So exchange lists that we include in our Canadian database right now is we use our Canadian nutrient database for our country-specific use. We also use brand name foods that will build in to the exchange list for the patients in their local areas. We, over time, historically have manually created these over using spreadsheets, and we've compiled them historically. It was upfront labor intensive by many dietitians and interns, etc., through many projects, but it was very sustainable once the database was established, and we only added a few products as we went along for certain, niche areas that families would be buying their food from. But we are in a time of using technology now, and so as we move forward, we wanted to keep thinking forward, and so now we were progressing to using of software, again, to improve the time and efficiency of a dietitian, but also to provide practicalities for our patients. Again, I'm a very strong proponent of pushing our dietitians to practice at the top scope of our practice, using your ketogenic dietitians to do the clinical work that they're trained to do, and using software can help them do that. So we do use technology, and we're developing technology here in Canada to help with recipe balancing and meal balancing, such as the Keto Suite software that is endorsed by Matthew's Friends Canada, and onwards. But there are many other softwares out there that can help generate your exchange lists for your countries. In summary then, so the low ratio slow outpatient initiation method remains the current method of practice at McMaster Children's Hospital in Hamilton, Ontario, Canada. It continues to be regularly reviewed for safety and tolerability. It is a method that has been trained in countries of similar healthcare funding models like New Zealand and Christchurch and other Canadian centers. The low ratio slow outpatient initiation method and the use of the food exchange meal preparation method, our preliminary snapshot data suggests that it supports high sustainability. We have no dropout and only discontinuation due to ineffective therapy, but we've had many patients on our exchange list. I know I only presented a snapshot, but we're very pleased with the data we're seeing so far. And then with the use of food exchange lists, we support, it's there to support the dietitian and the families to maintain sustainable and palatable oral feeding opportunities and to achieve meal plans that are practical and accessible for them. You can use software like the Keto Suite that can be used with multiple countries, and it allows the patient to become more independent to support sustainability. And there's other software out there like EKM, the Keto Diet Calculator, My Keto Planner, and many others that can be helpful in supporting your exchange list. And I think this is my last slide, so I thank everyone for taking the time to listen through and help allow me to share the experience we have here in our province and in our country. And I'm welcoming any questions that you have, and I'll pass the presenter ball over to Ellen.
All right, thank you so much, Jennifer, for that wonderful presentation. We have had quite a few questions come in, but I encourage anybody else to please put any further questions that you have in the Q&A box on the right-hand side of your screen. For all of you, we do welcome all of your feedback. So if you have any feedback, if you could please put that in the survey, we would love to hear from you. As we close out the webinar, you will be automatically directed to the survey, or you can take your phone and scan the QR code that is on the screen, or you can type in the survey from the address that is entered on the screen. After the survey, those of you who need, in the United States, who need a CE certificate, there is a code that is in the survey. You will take that code, write it down, and then go to www.nutritialearningcenter.com. You enter that code in the website where it says request CE credit, and that's where you can download your CE certificate from there. So without any further ado, let's get started with these questions, Jennifer.
Okay.
So we did have quite a few questions that came in about lab work. The first question about lab work is, what kind of baseline lab work do you do with, of course, this being an outpatient initiation? Do you do any baseline lab work, and what are the contraindications?
No, that's a good question. I believe I presented that at my initial presentation with in 2018. So that would be a place to refer to. But we do quite comprehensive blood work that is in alignment with the consensus statement, the international consensus statement. But to give you a quick overview of what we do, we'll do electrolytes, extended lights, liver enzymes, pancreatic enzymes. We'll also do a fasting cholesterol if we can achieve a fasting cholesterol for the family. And it's practical. And then we'll also do a vitamin mineral workup. So we'll do ceruloplasmin, selenium, zinc, vitamin D, the monohydroxy version, vitamin B12. If we can, we'll get a folic acid, not always. And I'm just trying to think. Oh, and we'll get an acyl-carnitine profile as well. If the physician deems it necessary, then we'll also do a metabolic screen workup via blood work. And I leave that to them to provide that, whether it be plasma amino acids or urine organic acids that they need to have provided. They will put that forward as well. And I forgot kidney function. We'll also do urea and creat function as well. The other baseline functions that we get pre-ketogenic diet for inpatient or low and slow method is we'll also get a baseline ECG, just because it has been reported in literature to be observed with the ketogenic diet. So we just want a baseline for comparison, and we'll measure that. We'll measure ECG as well as our blood work every 6 months thereafter. Ideally, we try to achieve it fasting if it's practical for the family.
Okay. And then, excuse me, you said that in one of the slides, you said that you would do lab work if you deemed it necessary. And in terms of acidosis, there were parameters for acidosis in terms of treatment. What is your cutoff for when do your patients need lab work and when do you treat for acidosis?
Right. So for our acidosis measures, we'll often ask symptomology also. So are they flush? Are they nauseated? Are they sleepy? And if we actually are hearing those sort of symptoms, we will send them to an outpatient lab. And our outpatient lab has the capability of doing a total CO2. If they're going to come into our hospital because they live nearby, then we'll get a VBG or a gas and look at the pH as well as the bicarb. If we want a number, we'll start to get more alert when that number is 17, bicarb is 17 or below, and if the pH is dropping. And then we'll make a decision as a team, looking at the symptomology as well as the numbers, whether to correct. And if you want a simple correction, we will typically just, if we're just correcting symptomology, we'll give 60 mL of juice, which is roughly 5.5 to 6 grams of carbohydrate, just to correct it. And usually it corrects fairly quickly if we're just looking at symptomology. And then the other, I might as well just answer this too. So our hypoglycemia criteria for our center, and it does differ from other centers, but we're more conservative. Our cutoff is 2.9 millimoles per liter. So a sugar that's 2.9 millimoles per liter, we don't even wait for symptoms. We just say treat that number and give 30 mils of juice, which is roughly 3 grams of carbohydrate, and remeasure that sugar within 15 minutes of treating with juice. As well, we do blood ketone measurements. We have that available here in Canada. We can do that at home using a very specific meter.
Went into my next question.
Oh, sorry, I got lost.
Nope, continue.
Can I continue? Okay.
Perfect.
So,
yep.
So blood ketone measures are possible. We'll actually add that to our every 6-month blood work. I don't think I mentioned that in my first round of questions. So beta hydroxybutyrate is what we're measuring in both either the lab measure or in the metered measure. We do have a meter here in Canada that we use, that we rely on, that does sugars and ketones together, and they help give us a quantifiable number of what's available in that's circulating in bloodstream. It's to be taken with a critical eye, of course. That number is going to climb in the initiation. It will stabilize during maintenance. It might climb again during growth or decline during stress, etc. So you have to look at it in context and not always look at it in relation just to diet. But we do use blood ketones. And again, people ask me, what is a high and how do you treat it? So in the very beginning, in the practical sense, when we're still titrating up the diet and still getting to know the families, if that number gets to be 6.1 or above and they look symptomatic with the flushing or nausea or excessive sleeping, and that's the symptoms they're reporting, we just say treat the number. Treat the number, treat the symptoms, and give 60 mils of juice, and then remeasure that blood ketone within 15 minutes. And again, those are very practical solutions. We very rarely see that side effect profile now because we're moving so slowly and the body's slowly acclimatizing to adapting ketogenic diet therapy to their metabolism. And a lot of the other sort of practical ways to circumvent the acidosis and the ketosis symptoms is just to drink. We give a lot of advice on hydration, to be able to drink enough water just to circumvent those symptoms. I hope that answers the question.
How often are your patients checking their blood sugars and ketones at home?
Yep. So blood sugars and blood ketones on the low and slow method. So blood sugars are going to be measured probably every, like 3 to 4 times a week. It is a bit, I think sometimes a bit much, but we're very conservative, so 3 to 4 times a week, and the blood ketones maybe once or twice a week. There's practical considerations because blood ketone strips aren't always covered by insurance, so we're aware of the costs. We educate a lot on symptoms and treating the symptoms rather than the numbers. So if you're feeling the symptoms, just treat it because you can always go back into the diet. It's not going to pull you out of ketosis if you give 60 mils of juice. So just treat the symptoms and see if you can remedy yourself better. But it does help to have a meter to help quantify and give numbers to your clinician. So to answer the question, sugars 3 to 4 times a week, blood ketones 1 to 2 times a week, and a practical one is urine ketones, and many centers still do that across the world because it's practical, it's inexpensive, and if we have that, then that recommendation varies. So we can maybe do that daily because it's not invasive, and just to trend it over time. And I ask the families to measure the timing of their blood ketones and urine ketones more towards the end of the day, so it's reflective of eating. So timing of measures is also important.
Okay, wonderful.
Yeah.
And then about when you are initiating patients, are you, what are you using for estimating their needs? Are you using RDA, DRI, or what if they're underweight or overweight? Are you wanting them to gain weight? I mean, how do you go
about approaching that? I love this question. Yeah. So a great practical question. So if you see back in my slides, I know you can look at this after this presentation is done. I am a believer in sort of diet histories. So I do try to gather diet histories. I think it brings big value in terms of eating practices, rhythm of eating, how many meals, how many snacks, what fits into the practical day. And I use that to create the meal plan forward. So if there is 3 meal, 2 snack person, then I will build that into the meal plan, making it forward so that that part is not changed in their lifestyle. So diet history is a place where I start. And I will calculate out the calories as well as the macronutrients of fat, protein, and carb and do sort of a deep dive into their nutrient profile. And I appreciate that there's disadvantages to diet histories, of course, but it's something that's available to us. In addition to that, I will also look at growth trajectory. If this is a child, I'll look at growth trajectory and see what has this child been doing in terms of growth. Are they reaching their growth potential, both weight and linearly? If this is a teenager, have they gone through the growth spurts yet? I'll be asking those sort of questions. And if this is an adult, I'll be, of course, assessing their weight appropriate for height, their BMI, etc., waist circumference. So all of those things will be anthropometrically analyzed. Diet history will be analyzed. And, of course, I'll go back to my equations of the Harris-Benedict equation if I need my adult, or I can go back to the Schofield equation if I need that. And then I'll also look at sort of the diet history and compare it somewhere to what those equations yield. And somewhere down, I usually make a decision. It's usually a blend of all those methods that I finally arrive to the appropriate calories for what I feel is good for my patient. And from there, I will evaluate that, of course. So anthropometrically, I'll be asking, what is the weight? What is the length? What is your, how are you feeling in terms of your clothing size, et cetera, as time goes on? And if the weight trajectory is not meeting its optimal, then I will adjust the calories to go up. If you're not losing the weight that you should be to achieve, a good healthy weight because you're overweight, then I will adjust the calories down, and so on and so forth. But I use a lot of sort of objective and subjective tools to assess to arrive to that calorie number. It's a great question.
Okay, thanks, Jennifer. We've got some more questions in here, and I understand some people may need to sign off, so we are recording this. If you can stay on, fantastic. I don't know how much longer you have, Jennifer, but we've got some questions about formula usage as well. So how are you able to transition patients via the low and slow method who are tube fed, and how would you do that?
Yep, absolutely. So it's a lot of what we do, actually. So we have many complex patients that are medically requiring alternative forms of feeding, whether it be exclusive G-tube or GJ, gastrojejunostomy tubes, or combination with oral. And we use formula, and we are using blenderized tube feed. That's sort of our broad scope at our institution. And certainly we will use our exchanges, or we can use our exchange lists actually to translate formula into sort of our prescription of 60%, 70%, 80% titration methods. We also use software it's quicker, to be honest. We can use the exchange system because we've built in all our formulas and our modulars, our protein modulars, our carbohydrate modulars into the exchange list. So it certainly can be done without software, and we can create the titrations that way. But we have software, so I use that sometimes as well, and I just, punch in my prescription, literally just punch in my prescription, and then it just generates my recipe, and it's very quick that way. And again, it lends to that moving your dietitian skill set to the top of your practice, where you're not, you're quickly making your choices of what composes your nutrition prescription. And you're letting software or exchange lists do the math for you, and then you as the clinician can review the math and make sure that the math makes sense, and then you can begin to implement it. So it takes some of that sort of administrative work out, but certainly we certainly do a lot of tube feeds using low and slow method, quite a lot. And of course we titrate slowly. You have to have a skill set on managing, how to manage and titrate up, how to manage feeding rates of G-tubes, etc., and GJ feeds. But if you work with a team, I'm sure that's very practical to do.
Okay. This next question is about the results that patients see. With the low and slow initiation, is it taking longer for patients to see results? The ratios are longer, or the ratios are lower. So are you finding it difficult to keep patients motivated? And then there's a follow-up question as well. So, not really for that one, but so do you have difficulty keeping families motivated?
From a motivation question, that's sort of where I guess you have empowering the families to. We try to educate our families up front going into it. So I think front up education is what we do before they even start ketogenic diet therapy, and we've thought about doing larger class sizes, but you dedicate that 2 or 3 hours up front to let them be informed of what they're going into, so that they can get into the right mindset. We look for signs in terms of their social situation to make sure that they're not making major lifestyle changes in other areas of their life that might thwart their success on the ketogenic diet. And if those changes in social situation are unavoidable, then we use a team around them to help make the diet sustainable for them. So motivation is manyfold by using front loading of education, and then also our sort of telemedicine model. And that's something I probably could have expanded on, but we do have a telemedicine model that we follow up with our patients every 1 to 2 weeks, and the dietitian will dedicate that time to them, so they know that they're always going to have a phone call or a video call with us within 1 week or 2 weeks, whatever is deemed necessary. And they can save up all their questions for that session, so it's more practical for a dietitian. And then they have that dedicated one-on-one time with us. And over a period of 4 to sometimes 8 weeks, they feel motivated to continue. We feel that that's to the point where they start to show us signs that they don't need to have our phone calls as frequently anymore. And in our model, we build in a 3-month clinic follow-up, just so that we can update the physician and the nurse practitioner or nurse, just so that they can see, how far we've come and evaluate if any medication changes can happen. So between the onset of education to the start of the diet all the way up to 3 months, they're in contact with our team fairly regularly by about 1 or 2 weeks. So that's probably part of the motivation piece as well. Now, I guess the other question, yeah, I'm going to go back. Can everyone see these slides? Can they, Ellen? I'm just going to backtrack a bit.
Yep.
Can they see this?
Nope,
okay, sorry.
Yep.
Yeah, and I'm going to use my backspace skills here, seeing if I can. Oh, can I advance the slides a bit? No? Oh, yeah.
Yeah, you're the presenter. You can.
Okay, very good. I'm just trying to see my methods here. So if you see here on this slide, the question was, are we seeing efficacious seizure results? So I do believe that we are. If you look at this slide here, and I know I went too quickly, but you can see in the teal, sort of the green font down below, you can see that about towards the 3-month mark onwards, we had people who had about 30%, greater than 30% of our patients had greater than 90% reduction. And that was sort of sustainable up to the 1-year mark. We've collected data beyond the 1 year, but that's all I have right now to show you. And then those that have 50 to 90% reduction, again, it's somewhere between 36 and 45%, which I believe if you compare it to the large cohort studies like of Johns Hopkins, it's very comparable in terms of response rate within these sort of descriptive parameters. I hope that answers that question. And I guess the take-home message
leads into.
Yeah, go ahead.
This leads into the next question is, this person is new to keto and has taken it on with the pandemic that's been going on. And she's been struggling to figure out what is an appropriate ratio for patients since you are having such good success with the lower ratios. So she was just asking what is a good ratio for patients to be on, and so you're showing success with the lower ratios. So
yeah, it's a harder one to. Yeah, it's a harder one. If I go back again, sorry, I went backwards. If I were to go back, we seem to be sitting around a 2-to-1 ratio, but I'm not going to say that that's going to be the therapeutic ratio for your patient. But remembering that, you know, we have sort of restriction on our carbohydrates. You know, we meet the requirements for our patients. We try not to exceed too much on our protein, pardon me, and so the protein remains a constant value, and then we adjust the fat and carbohydrate around that. So I would fine-tune the diet. If you're already at a 2-to-1 ratio, I would tighten up the protein and see if you can get it up to maybe a 2-to-1 ratio. But again, it's individual. Some families can achieve seizure control at a lower ratio. And sometimes it's not just the ratio that matters. Remember that you can mix up the fats a bit to build in some MCT, which will strengthen the diet itself, and it is not reflective in your description of percent calories from fat. It is a much more quickly absorbing fat that can create ketosis very, very quickly, ketones very quickly. So it's not built into your prescription per se in terms of the percent calories from fat, but it is a fat choice that you can make to strengthen the diet, even if you're at a low ratio.
Okay.
And I think I demonstrated a case of that in that example. Yeah, no, thank you.
Yeah, no. We have a lot more questions, but unfortunately I don't want to take up too much more of people's time. So I will get with Jennifer and we will try and get those answers for you all. But with that, I want to say thank you, Jennifer, for this fantastic presentation, and thank you all for your excellent questions throughout the presentation and afterwards. Our next webinar will be on Monday, June 1st. For those of you who would like to dial in and attend, we will have Dr. Kossoff presenting for us on the upcoming, his thoughts for the future of the ketogenic diet as it enters its second century. We will have a copy of the handouts up on Nutritional Learning Center, and I will be I am going to post the link for the handouts again in the Q&A box. So all of you can go directly to that link. For those of you who would like to see that link, it will be in the Q&A box. So you guys can get a copy of the slides from there, as well as a CE certificate. If you fill out the SurveyMonkey, you can get the code for the CE certificate if you go to nutritionallearningcenter.com and enter that code in there. And if you need a copy of it, the certificate of attendance, if you are outside of the United States, feel free to email me. My email address is in the thank you email that you will receive from there. And with that, I thank you all and hope you have a wonderful day. Thanks a lot, everyone.
Thank you. Thank you, everyone.